Alrighty, week 8, psychotropic Pharm stuff. Okay, so psychotropic is the definition, or implies it is an alterative mood, or alters mood, perception, and consciousness, whereas an anxiolytic is pretty self-explanatory, decreases anxiety. Sedative and hypnotic are oftentimes used incorrectly interchangeably. A sedative is just like a tranquilizer. It can put someone to sleep, but it's not like a sleep cycle the way that a hypnotic is. A hypnotic is to help, like Ambien, is to help actually make a person sleep. Whereas a sedative is sort of more of like a forceful thing, or something where you calm the person down and they may not be asleep, but they're not going to be any longer combative. Okay. So psychotropics in general, antipsychotics, are used for delusional disorders like schizophrenia or depressive psychoses, which we may see also in bipolar disorder. They are not usually used in dementia. Dementia is not the same kind of problem. That's a brain degenerative problem, which kind of is what schizophrenia is also, but it's a different process altogether. They may use some antipsychotics for certain symptoms, but not for the diagnosis. So antipsychotics come in two different flavors. We got our first generation antipsychotics and our second generation antipsychotics. The first generation ones are cheaper. I believe they both work as well as the other. The problem with first generation is that we have extrapyramidal symptoms. These symptoms have tremendous levels of stigma associated with them because you can tell right away if someone has schizophrenia or is on an antipsychotic if they are presenting extrapyramidal symptoms. And some of them are downright just horrible. They're terrible symptoms to have. They are treatable, except for one, but people really hate these extrapyramidal symptoms. Whereas with our second generation, I don't know, actually I think the other part might be down there. The second generation tends to have a stronger metabolic syndrome kind of effect, which is not as socially stigmatizing, but it could have stronger lifelong overall health mortality impacts. So with our first generation, or conventional antipsychotics, the reason that these cause extrapyramidal symptoms is because they primarily block a tremendous amount of dopamine in the brain. They also block other neurotransmitters like acetylcholine, histamine, but the primary one that they block is dopamine. They also do a little bit of norepinephrine, but whereas the second generation, they don't have a super high level of dopamine blockade. They've got sort of a more moderate level, and then that, like, how much they impact other receptors and neurotransmitters is really kind of more spread out evenly amongst a bunch of different receptors. So that's why we experience fewer EPS with second generation. So our primary use of these are going to be schizophrenia. We want to try to We want to try to control acute psychotic episodes, and then we want to continue their use to reduce the risk of relapse. So when it comes to the adverse effects, the extrapyramidal symptoms that occur, we have 4 for us to be aware of. We got first our acute dystonia. This is going to be, this is going to look like someone who's got maybe their back, their neck, their eyes, something is muscularly is locked. It's contracted, it's locked, it can be very painful, and again comes from the over blockade of dopamine with first generation antipsychotics. So specifically under acute dystonia, we have some certain symptoms that can occur. Oculogyrate crisis is going to be where we have the eyes rotated upwards towards the top of the head and locked in place. Opisthotonus is where it's like tetanus. So you've got the back is arched, so the chest comes forward, the abdomen comes forward, the back, the back of the head and the neck cave backwards. The arms kind of go backwards as well, and they lock in place. It's a very, very painful position and contraction to have. In that, we can also have joint dislocation because our brain doesn't have the proper connection with the muscles to find out that, oh, we've got too much contraction going on here. We've got too much tension. Let's calm it down. Instead, the muscles just keep on contracting, contracting, and we can pull joints apart. And then, of course, with something like opisthotonus, we can have impaired respiration because if you're put into a position that doesn't allow for full expansion of the chest, you're not going to be able to breathe fully. We can treat this with most of these, we can treat with anticholinergics. So, for example, diphenhydramine or Benadryl. And something that kind of made a few of us confused in our cohort is the idea that anticholinergics and antihistamines are often the same thing, just so everyone's aware. Another form of EPS is Parkinsonian's syndrome. Again, this is treatable with anticholinergics such as diphenhydramine or benztropine, which is another more common medication to give as a EPS controlling medication for people taking first generation antipsychotics. So this really just looks straight up like Parkinson's. It's not Parkinson's. It doesn't have the same degenerative behavior. And stopping the medication or treating it with anticholinergic medication should completely resolve it. But they're going to have the same kind of mask-like faces where it looks like they're expressionless, drooling, tremors in the arms and legs, rigidity, cogwheeling in the wrists or lower arms, that shuffling, stooped gait posture thing. Next we have our akathisia. This is going to be where people are not able to hold still. They are literally unable to hold still at all, and it's blatantly obvious. This is one that has led to a number of people who have not been able to get treated for it because lack of access or they didn't know to get treated. People with schizophrenia oftentimes have severe cognitive impacts from schizophrenia, and so they may not think about being their own advocate and saying, I need to get this fixed. They just think something's wrong with me. And so this has led to a lot of people committing suicide because it is awful. They can't sleep. They can't function well. But luckily, it is treatable. We can treat it with beta blockers, benzodiazepines, and again, anticholinergics. Lastly, we have our tardive dyskinesia. This is going to be the most sort of classic reaction to antipsychotics. And this is going to be where we have that lip smacking or tongue flicking, worm-like tongue movements, really kind of distinct facial repetitive movements that once you see it, you recognize it on anyone who's got it. This, unfortunately, with it being probably, when it comes to just the presentation of it, I think this might be second worst after akathisia. This is irreversible, which is really bad because this, amongst all of them, probably have the greatest social stigma associated with it, which can severely impact the already fragile mental state that a lot of these people may have. Once we see that they have tardive dyskinesia, we're going to want to simply stop the medication and try to find something else to take instead, like a second generation. Another severe adverse effect that can also occur is neuroleptic malignant syndrome. This is a life-threatening, severe situation. It's very similar to serotonin syndrome, and it's manifested as a super high fever, severe cognitive impact, confusion, not having any awareness of what's going on. If you look it up on YouTube, there's actually a video of a guy who had a temperature, I think, of 106, which is absurd. Had no reason not to die. That should have killed his brain. And actually maybe even higher than that. But he had so much confusion and he was so disoriented that he had to have actually put mitts on his hands because he kept on ripping stuff out of him. And they had to put barriers on the side of the bed to protect him from smashing his arms or face against the bed. He was secured. It's a horrible, horrible situation. I believe the guy still lived through that all and recovered. But it's a very distinct picture in your brain, and once you see that, you really don't forget that. There can be massive fluctuations in blood pressure, so that we have hypotension to hypertension, dysrhythmias, a lead pipe rigidity, so they're like stiff as a board. And then there's a 4% mortality rate from all of this and comes from seizure coma death. Luckily, it is rare, but it's something that we need to educate our patients on so that when they notice some symptoms associated with it, get to the ER like right away. We have some other adverse effects of taking antipsychotics, such as anticholinergic effects, which include things like dry mouth, blurred vision, photophobia, so like a fear of light, or just light sensitivity, urinary retention, constipation, tachycardia, and also orthostatic hypotension. But in this case, orthostatic hypotension is also something that is caused specifically by other parts of the drug action, specifically being that antipsychotic agents can block alpha-1 adrenergic receptors on blood vessels. And so we got like our beta-1, which is for the heart, beta-2, which is for the lungs. We also have our alpha-1 and alpha-2 receptors in the CNS, or in the nervous system. And the alpha-1 receptors are responsible for constriction of blood vessels, or constriction dilation. Activating alpha-1 will cause constriction of blood vessels to improve blood pressure. So if we block alpha-1 receptors, then we're not going to be able to maintain blood pressure as well, and so they're going to be at risk for severe orthostatic hypotension, which, education-wise, take it slow, especially as you first start the medication. Sit up for a bit from a supine position and let yourself kind of accommodate for a couple minutes, then stand up, make sure you have something to hold on to, or that you're ready to, like, if you're getting up from bed, you're ready to plop back onto your bed in case you start to feel dizzy. We have some other adverse effects as well, like sedation. This will subside over time. Seizures, sexual dysfunction is very common. 25% to 60% of patients will experience some form of sexual dysfunction. I don't know whether that's something that will subside over time as well, but that's something that realistically they're going to care about a lot as patients. We can also have another really unfortunate side effect through the way of neuroendocrine effects like gynecomastia and galactorrhea. So that's development of breast tissue and then the actual development of milk through the breasts. And that can happen both in women who are not pregnant and in men, which is really doubly unfortunate for men. So your penis may not end up working, and you also then develop lactating boobs. So, I mean, that would just be awful. You can also develop some dermatologic effects, some rashes. Agranulocytosis can be a life-threatening issue, a severe life-threatening issue. It's not super common, but it is potentially able to happen. And agranulocytosis is specifically referring to granulocytes, and most often than not, that would be neutrophils, a form of white blood cell. Most commonly that occurs from chlorpromazine, which is a type of first-generation antipsychotic. We also have the risk of severe dysrhythmias. So we can start off by having that QT interval prolonged, making it so that it takes longer for the heart to repolarize completely and get ready for its next beat. Over time, if it prolongs enough or is prolonged long enough, then we can develop torsades de pointes, which is actually a kind of a form of VFib, or ventricular fibrillation, which is life-threatening, requires magnesium sulfate to treat. Just a little tidbit there for you. And is kind of it's a really kind of a cool rhythm, actually, torsades, in that it looks like a crescendo decrescendo of VFib. So look it up sometime. It actually is kind of cool to look at, and when you notice it, you're like, oh my god, that's torsades de pointes on a patient. Patients can also develop physical and psychologic dependence. This is rare, but when they do have some dependence, the abrupt withdrawal can precipitate a mild abstinence syndrome, which will look like having restlessness, insomnia, headache, gastric distress, and sweating. So we don't want to have abrupt withdrawal. Some patients may say, like, I need to get off this medication, switch to another one. Okay, we can try to figure out how to accommodate that, but we're going to have to do this slowly so that you don't end up having a really nasty abstinence syndrome. We want to make sure we're providing beneficence to our patients. So we also, if we have any other anticholinergic drugs that are taken with these medications, since they have a strong anticholinergic effect, then we're going to simply intensify, potentiate those anticholinergic effects. So if we take antihistamines for allergies, or sleep aids, NyQuil, or something like that, there's a good chance that that's going to potentiate those anticholinergic effects. We want to educate them on the concerns of taking any CNS depressant while on this medication, such as alcohol, antihistamines. Antihistamines just seem to be like a big problem here. Barbiturates, benzos, because they're going to also potentiate that depressant effect. And then levodopa is a medication that is used oftentimes with Parkinson's. They're normally given levodopa and carbidopa to try to promote more dopamine in the brain, in the CNS, to treat Parkinson's syndromes or symptoms. But of course, this is going to decrease the antipsychotic effects of our medications, since the purpose of especially the first generation antipsychotics is to reduce dopamine amounts in the brain or in the CNS. So this one's interesting. We don't know exactly how to, or I'm not sure exactly how this would be balanced, but I'm sure there'd be ways that the professionals know how to do it. So on to a specific antipsychotic, haloperidol or Haldol is a very popular antipsychotic. I've seen it more often used as a very short-term behavioral emergency drug. So like first responders, paramedics, EMTs may use this on patients who are being or who have severe behavioral issues at the time that they find them, or this may occur in the hospital setting, but I don't think Haldol is normally as much used there. I think Ativan's more used in the hospital setting. But we're going to use this for, also we can use this for regular prescription medication to treat schizophrenia and acute psychosis. It's also, according to the book, able to be used with Tourette syndrome. With Haldol, it has a very high potential compared to other antipsychotic agents of promoting EPS, or extrapyramidal symptoms. We also still have a high potential for neuroendocrine effects, such as galactorrhea, gynecomastia, and menstrual irregularities. And then, as with back earlier on in the lecture, or this thing, dysrhythmias. So there's always the potential for dysrhythmias with Haldol. The same dysrhythmias through QT syndrome, torsades to VFib. Chlorpromazine, or Thorazine, I think Thorazine was the older name, they may have changed it, is good for schizophrenia, mania with bipolar disorder, or emesis, vomiting. It has a strong sedation effect, a strong orthostatic hypotension effect, and anticholinergic effect. And then this one, as was mentioned earlier, is also a strong promoter of agranulocytosis, which can be life-threatening since if you don't have your neutrophils to fight along with the other white blood cells, any potential invaders, you're more likely to get sick. So now we have our second generation antipsychotics, which were introduced in the 1990s. They have less risk of EPS, which is great from a comfort and social stigma perspective, but they have an increased risk of metabolic syndrome, specifically with weight gain, diabetes, and dyslipidemia. They're also, unfortunately, 10 to 20 times more expensive. Like, that's really expensive. Risperidone is a popular atypical or second generation antipsychotic. It's used for schizophrenia, mania, Tourette's. Luckily, the adverse effects are infrequent and they are mild. Gynecomastia is still one of them, and insomnia is one, which means that we may want to be considering saying to our patients, take this in the morning, since you'll have less of a chance of insomnia. Aripiprazole or Abilify, a lot of time you've probably seen plenty of commercials about Abilify, used for schizophrenia, mania, and major depressive disorder. Similar symptoms or side effects: headache, nausea, vomiting, agitation, anxiety, insomnia, somnolence. Yeah, there was all that. So I guess those are our two second generation meds to be aware of. These are the ones that I have seen, at least, most commonly in the patient setting. When it comes to the major objectives, we want to make sure that we are suppressing the acute episodes. We don't want people to be going out and having an acute psychosis or acute psychoses. That becomes really dangerous for them. We want to prevent acute exacerbations and maintain as high level of functioning as possible, provide them with strong social support systems, lifestyle or life skills support, education. Most of the first and second generations are equally effective, and there's a significant risk, we've already covered this, of EPS with the first ones, lower with the second generation, but these ones cost a lot less, and these ones have a higher chance of metabolic syndrome. Let me go on. Patient adherence for these can sometimes suck, because these patients may, at the times when they're feeling good, think, I don't need these medications. I've had plenty of patients tell me that we're trying to control them by giving them medications. Schizophrenia is a nasty condition. It really screws the person's perspective and makes it difficult to really reason with them sometimes. So we really want to try to promote adherence in some way possible. So if they are inpatient, we want to view them taking the meds, and that includes things like, let me see around your lips, let me see around your gums, flip your tongue, say ah, all these things, and let me see your hands to make sure that you're not taking the medication and hiding it somewhere. You're actually taking the medication. That happens on a very frequent basis, unfortunately. For outpatient, we would want to encourage, say, a family member, someone to be able to kind of oversee their taking of the medication, because that way we can ensure that they are taking it. We need to be teaching about the how to take the medication and the side effects of taking the medication, and that they need to be taking the medication on schedule, because if they don't, they're at a high potential of experiencing a psychosis. We also want to promote counseling. We want to promote counseling for the patient and the family, since schizophrenia can have a very significant, very severe impact on the family dynamics. It can be very stressful, and having counseling to help sort of communicate between parties and help each other figure out how to support each other can really be helpful. CBT, cognitive behavioral therapy, and dialectical behavioral therapy are two that are really, really great for those with schizophrenia. They're both offered at Oregon State Hospital for their inpatient population. And they have options as well. I don't know where the options are. The communities are not necessarily known for having great schizophrenia support. And then vocational training is great because getting them into a job, something where they can find themselves feeling valued, something where they can see themselves being successful, skillful, will help to give them or see how they have more to lose if they don't stay with their medication adherence. Okay, bipolar disorder. So, bipolar disorder has recurrent fluctuations in mood, episodes of mania and depression. It's persistent if not treated. We can do treatment through drugs and psychotherapy. The main medication we're going to be using is lithium. Lithium is our like godsend for bipolar disorder. It works really well, but it has a lot of problems with it, unfortunately. It does relieve manic and depressive signs and symptoms. Just giving antidepressants can be problematic with mania. It can be okay with when you're having a depressant episode, but it can be problematic when given as on its own as to treat mania. And so providers need to be careful on how they're providing or how they're prescribing. We can also use antipsychotics for the severe manic episodes. They do work well for that. So bipolar disorder, oftentimes, from what I understand, will be kind of bouncing back and forth from certain medications to certain medications. Lithium may be like a standard, like at all times, and then they have other ones to treat sort of the symptoms that come up as they come up. Let's see here, polar bears. So we want to do our patient education to the family and the patient. Encourage psychotherapy for the individual in a group setting and for the family dynamics. And then as we can see here, this is what forced ECT would look like according to how to, One Flew Over the Cuckoo's Nest. And as a last resort, they don't force people like this anymore, which is great. So with lithium itself, it is a simple inorganic ion. It is very, very similar to sodium, and there's more about that in a minute. And it's found naturally in animals. We don't have a clue how it works. We just know that it does. So that's wonderful. It is excreted through the kidneys, virtually unchanged, and it will have decreased excretion when the sodium levels are low. That's important because lithium has a very narrow therapeutic index. So if we've got a patient who's on, like, say, the DASH diet, they've got hypertension, or they have hyperlipidemia, something that encourages like going on a low sodium diet, they are at risk with a low sodium level of having lithium toxicity, because lithium's like a salt. You can think of it as like having the same structure as a salt. And so when a person's salt levels go low, the body is going to be trying to reabsorb it as much as possible. And so when we have plenty or not enough salt, the body's going to pull lithium out of the renal tubules back into circulation and keeping it all there. Whereas if we have plenty of salt, like, not an overabundance, but a normal amount, maybe a little on the higher side of normal, then that's going to promote renal excretion of sodium because the body's like, oh, hey, we've got plenty of this stuff. Go ahead and let it go. And so that ensures that lithium gets excreted and we can maintain a proper lithium level in the body. So lithium's adverse effects, we've got nausea and vomiting issues, tremors. Because we have the fact that it's going to promote, granted that salt is, or sodium's at the right levels in the body, promote water loss, we're going to have the potential for polyuria, thirst, and dehydration. There's also the potential for hypothyroidism because lithium can reduce the incorporation of iodine into the thyroid hormones and also can inhibit the thyroid hormone secretion itself. So there's a potential for hypothyroidism. I don't know what they do to try to help that or change that, accommodate that. Maybe giving Synthroid might be the only option. It's also teratogenic, and so they need to make sure that they are taking contraceptives while on lithium. If they want to get pregnant, then we got to figure out what ways we can manage to. We have to first take off lithium, and then we got to figure out how we can manage the bipolar disorder symptoms while they try to have kids. Like I said, it has a very narrow therapeutic index, and so when we are giving the medication off the bat, we're going to need to check the levels every 2 to 3 days for, I think, about a month, I think, or something like that, maybe a couple weeks. It depends on how long it takes for them to reach the proper therapeutic index and keep steady at that point, at which point then we're going to want to check every 3 to 6 months to make sure that it's not changing out of that. When we have lithium toxicity, we're going to have an increase in the adverse effects up here. There we go, up here, as well as having renal failure, which is going to be coming from the fact that we have the excretions exclusively through the kidneys, and so it can cause some funky stuff there. And then ataxia, uncoordination, coma, and death. We have some drug interactions that are specific to lithium that are based a lot of times off of their excretion. So, for example, diuretics. If we are encouraging urinating more frequently, this might lower the medication to a lower point than is therapeutic. So we want to keep it in that therapeutic range if we're giving diuretics and causing a lot of urination, then it may go lower. Similarly to kind of potassium, I don't know. No, it shouldn't. I think it should go lower with diuretics. I don't remember. I'm going to look that up real quick. I was wrong. So with diuretics, you can expect the lithium levels to go up because with diuretics, we're going to be losing salt. Doesn't necessarily mean we're going to be losing a lot of lithium. But with loss of salt, the body's going to try to hold on to whatever salt it can. So that's going to result in more lithium being held in the body, leading to higher levels of lithium with diuretics. NSAIDs will also be problematic in that they can lead to, one, shunting of blood to the kidneys, making it so that we don't necessarily have as much renal excretion of lithium. But also we can have more renal resorption. Hang on one second. So NSAIDs promote more renal reabsorption of lithium back into the body from the kidneys. Don't really understand exactly why. But yeah, so just remember that diuretics and NSAIDs, they will both indicate or both result in higher levels of lithium. So anticholinergics also, I believe, come on. What are you doing? Okay. I thought I looked this stuff up. I gotta figure out now why anticholinergics are a problem. So anticholinergics promote urinary hesitancy, urinary retention, but lithium will promote a need for urinating more often, polyuria. So combining them together will promote a situation where the patient has a strong need to urinate without having like the bladder's readiness to urinate, which can make it very, very uncomfortable for them. Okay, so sedative hypnotics, these suppress the CNS functions used for anxiety and insomnia. And the dosage really is what determines the difference between a medication being an anti-anxiety, an anxiolytic, versus having hypnotic effects. So you give a little bit of Ativan, and we are going to have just some nice anxiolytic effects, but not really any cognitive effects. You give a giant dose of Ativan, and all of a sudden they're on the bed unconscious. Some of our options here are going to be benzodiazepines, benzodiazepine-like drugs, and barbiturates. One of our favorite benzodiazepines is lorazepam, or more commonly known as Ativan. Benzos are safer than barbiturates because they have a decreased potential for abuse. They have a decreased potential for tolerance and physical dependence, and they have fewer drug interactions. That's all good stuff. We like that. Benzos, like the lorazepam, are going to be used for anxiety, insomnia, seizure disorders, specifically with the like status epilepticus, just to knock off the seizure itself, and then use other medications to try to control the seizures long term. Muscle spasms, alcohol withdrawals are great. They can help with those symptoms. And then used to help with inducing anesthesia or doing conscious sedation. Yeah, I'm not going to go into that. They do, of course, have some adverse effects. CNS depression is great when we want it for that purpose. If we don't want it for that purpose, or if we don't want to have CNS depression, then we don't like CNS depression. We don't want people taking benzos and going and operating heavy machinery. People will die that way. There's a potential for amnesia, which can actually be used therapeutically. And there are times where that can be used maliciously. So I've actually heard of a time where a doctor said something about a patient thinking they were already unconscious. The patient wasn't, like for a procedure, the patient wasn't unconscious yet, and they were very concerned or upset about what the doctor said, thinking that no one else but medical personnel were hearing him. And he was like, hey, go ahead and give her some Versed. And that had what's called retrograde amnesia to take off about 15 minutes of her memory. So they can be good, it can be bad. Depends on how we use it. With power comes great responsibility. It can also have paradoxical effects in that people who we want to try to get CNS depression, anxiolytic, or hypnotic effects, we end up making them more energetic instead. It can also promote mild respiratory depression, not on the level of opioids, but similar. And they still, while they have a reduced chance compared to barbiturates, they still do have the potential for abuse and for physical dependence. Of course, you mix them with anything else that has CNS depressants or respiratory depressants, you're going to have a potentiated effect for both of those. And of course, we can have toxicity. If it's taken in the oral form, this will result more often than not just on the pronounced CNS depression effects, so drowsiness, lethargy, confusion. If we give toxicity or promote toxicity via the IV route, this could result in life-threatening hypotension, respiratory arrest, cardiac arrest, death. So we always want to make sure we are aware of how to use flumazenil as an antidote. This is a competitive benzodiazepine antagonist. So we gotta give enough of it to get the benzos off of their receptors, and may need to keep up on providing some dosages depending on how long flumazenil is working and how big of a dose we gave as an overdose for IV. Ambien is going to be our most widely used hypnotic for sleeping. It is used for insomnia. The approval is limited to short-term use, but a lot of people do end up using it long-term without having any issues with tolerance or an increase in adverse effects. So we need more research. And the side effects of this are going to be, of course, drowsiness, dizziness, and really fun hallucinations.